Okay, good day everyone. You're welcome back to Dr. Sakwe's lessons or Dr. Nusa's lessons. What we are trying to do is to make some aspects of clinical chemistry very simple so that when you get back to your notes, you'll be able to understand. You get back to your text, you get back to your notes, you get back to anywhere you study from. You'll be able to have easy understanding of whatever you are studying. So we're going to continue by starting with hyponatremia. We're going to talk about hyponatremia in this series, hypernatremia, and then hypokalemia and hyperkalemia in this series. So we begin with hyponatremia. Hyponatremia is simply sodium concentration that is lower than 135 millimoles per liter. Sodium concentration in blood that is lower than 135 millimoles per liter. Now, hyponatremia can be classified based on osmolality into hypotonic hyponatremia, isotonic hyponatremia, and hypertonic hyponatremia. So we begin with the isotonic hyponatremia. Now, we realize that when we measure sodium in sample, collect sample from an individual and we measure sodium, the sodium that we actually measure is the sodium in the aqueous part of that solution or in the aqueous part of that sample. Now, what that means is that it is the sodium that is in the water or the water soluble part of that sample that we measure. So that means that if there is the presence of, for example, lipids or maybe um, mm, yes, lipids or maybe proteins, high proteins in that sample. Now, those components will reduce the aqueous part, the volume of the aqueous part of that sample. And remember that what is accessible to us for us to be able to measure sodium from is the aqueous part of that sample. So the presence of lipid in that sample can cause interference. The presence of high protein in that sample can also cause interference. And the presence of lipid and or high protein will it therefore reduce the volume of the aqueous part of that sample. So when you are measuring sodium in that sample, you are only measuring the sodium that are present in the aqueous part of that sample. So in that situation, once you measure sodium will be low because the lipids and probably the protein concentration that is high was covered or used up or covered up some part of the aqueous, some of the aqueous part of that sample. So what you have left is the reduced volume of the aqueous part of that sample. And so when you measure sodium, the sodium you are measuring will now be only the sodium that is in the aqueous part of that sample. So when you measure it, the result will appear low. It will come out low. So what that means is that the sodium is low, but the tonicity of the sample is the same. Is not low and it's not high, right? But because of the presence of interferences such as lipids and protein, it will cover up the aqueous part, reduce the aqueous volume of that sample that is available for you to measure sodium in. So the bottom line is that sodium will be low because you measure only the sodium available in the aqueous part of the sample that has been reduced by the presence of lipid and proteins in that sample. So in situations like a patient having hyperlipidemia or a patient having multiple myeloma, this kind of situation can result in it can result in hyponatremia that is due to reduction in the aqueous part of the sample, and that is isotonic hyponatremia. And this causes or this isotonic hyponatremia is known as pseudo hyponatremia because it's not that the total sodium in that sample is actually low, but it is the total sodium that is available for measurement that you got. So this will not be a true reflection of the patient's or the individual's total sodium concentration, but because the sodium concentration that is available for measurement is reduced, and so what you have there is pseudo hyponatremia, and that is isotonic hyponatremia. So the next one we'll quickly look at is the hypertonic hyponatremia. Hypertonic hyponatremia. Now, this one can result from increase in glucose concentration, like in a patient who is diabetic, then increase in or the presence of mannitol, mannitol in the system of any individual. These ones can create a hypertonic environment. And then also it can be um, it can be caused by maybe a use of certain what do you call it, radiograph or radiographines. There are some certain contrasts that are administered to certain patients. When you collect sample within the period of that time that the contrasts have not cleared out of the system, it can cause hypertonic hyponatremia. Now, what these things do is that they attract water into the extracellular compartment. These substances, they attract water into the extracellular compartment from the intracellular compartment because of high osmolarity. So the flow of water now from the um, intracellular compartment into the extracellular compartment will now cause a dilution in sodium concentration. And so because of this dilution in sodium concentration, when you measure sodium, the volume of sodium you are measuring against the total fluid or against extracellular fluid will now be low. And so when this happens, it is also another form of pseudo hyponatremia. Now we particularly look at glucose. When glucose concentration is high, remember that it is high in the extracellular compartment. Now, this high glucose concentration in the extracellular compartment will create an hypertonic environment. And so because of that, there will now be automatic movement. Remember that when in osmosis, there's movement of fluid from a region of movement of water from the region of lower concentration to the region of higher concentration. So when there is a hypertonic environment as a result of either glucose or either high glucose or mannitol. Now, mannitol is a substance that people use as sweeteners. Now, the use of mannitol can also cause a hypertonic environment in the extracellular compartment. And then also the use of urographene rather, or any other form of contrast that the radiologists use when they administer to people so that they can have a contrast when they take an x-ray of certain parts of the body. Now, use of any of those things can create a hypertonic solution. And when this hypertonic solution is created, there is now a movement of water from the intracellular compartment to the extracellular compartment to now, with that migration movement of water massively into the extracellular compartment, when you collect sample in that state, there is now a dilution of the sodium concentration in the individual's bloodstream. So it is not that the total sodium concentration is reduced per se, but because of that dilutional effect that is as a result of the fluid that has moved from the intracellular compartment to the extracellular compartment, that effect generally will now result in a low sodium concentration, because when you measure, remember that you measure sodium per volume. So if you are measuring, the volume is high and sodium is not, it's not that sodium is low, but the volume is high, it will bring down sodium. Sodium becomes low. So that will result in a hypertonic hyponatremia, which is also a pseudo hyponatremia, because it's not actually that the patient's sodium concentration is low because of the hypertonic environment that has attracted the inflow of water or fluid of water from the intracellular compartment into the extracellular compartment.